Welcome to Boombastic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change. Each week, we bring you candid conversations with top experts, innovators, and leaders, exploring the latest trends and technologies shaping the future of healthcare. Join us and be part of the conversation in transforming healthcare. Well, hey, everyone. Welcome back to another episode of Boombastic Health. I'm Bradley Bostic. We are on episode 19, and we've got a fantastic guest here today, Dr. Chris Crossett, who, in full disclosure, is another one of my team members at HC1, where I'm CEO. But Dr. Crossett is incredibly accomplished in a number of areas, including lab stewardship, which is the idea of making sure patients get the best possible testing in order to diagnose them effectively, in order to help prevent illness, and also eliminating wasteful testing. So we'll talk some about that. Dr. Chris Crossett is also an expert in supply chain management, and we're going to focus more on lab stewardship in today's episode. And this is the third in a three-part series here where we've covered an array of capabilities that our clinical solutions address within HC1. So welcome to the show, Chris. Thanks for being here.
Thanks for having me.
And you're in the northern Indiana area. It sounds like you guys have been getting some tornadoes. Is that right?
Yeah, we're about 60 miles south of Chicago, just over the Indiana border. So last week we had one that came through our town, and there was a couple the other night. So it's been an eventful March so far. Not the normal snow that we'd expect right now. Just some interesting weather.
That's crazy. Well, glad you're safe and able to hop on here to talk through this really important topic. So maybe you could just lead in by giving your own version of, hey, tell us your story. How'd you get in healthcare? What's your passion?
Yeah. Actually, Bradley, my story is pretty similar to yours almost. My whole family was in healthcare. First and foremost, my father was, my mother still is. She works as a administrator over in Illinois, and it's something I've always wanted to do. My little sister, she started down the nursing path before she fell ill with complete dysautonomia, and we lost her coming up on 4 years next month. So that was really the driving catalyst. She was ill for a little over 12 years, and just wanting to get into healthcare, try to make a difference. I started out at the University of Chicago Health Systems. That's where my mother was at for a period of time, and worked my way up. Supply chain, did a little bit of research for them over there, and just continued to grow my knowledge base. And then from there, a company called Acumen recruited me out of there, and the rest is history, so to speak. But it was a personal drive that got me into healthcare from, something that my parents were doing. And then, with my sister, it just wanted me to excel in this space. And it really pushed me over into the lab side. And it's been a great move.
Well, we're glad you're here, and sorry about what happened with your sister. And as you said, it certainly reflects an experience that I had with my mom, and also I think what so many people have had. And I think that's what makes healthcare such a worthwhile career pursuit, is that it affects all of us at some point in a really profound way. And to have a chance to make a dent in that and make healthcare better for people is important. And in addition to the fact that clinically we need to make sure that the best decisions are being made to help people prevent and get better faster and have longevity, we also have to be mindful of the bottom line. So it's just the reality is, if there's no margin, there's no mission. And I know a big part of what you do actually impacts both the clinical effectiveness, but it also drives up the bottom line for the actual healthcare systems, the healthcare providers, which then allows for this virtuous cycle of improvement. And I think that's what makes it really powerful. And what this whole podcast, the way it was spawned, is I kept hearing from innovators who were having success because they had combined some type of innovation with an economic engine in healthcare. And I also saw a lot, and still see a lot, of people who have not been as effective at the economic side. So you might have a beautiful innovation that makes all the sense in the world for patients, But if it doesn't connect to the right economic engine, you end up falling short. And I think it's really cool what you've specialized in allows for both that success financially as well as clinically. So let's focus on lab stewardship here, and the fact that you can be more precise with diagnostics. Would love to hear your point of view on that space, and what are we doing to truly affect the health journey of patients by bringing the kind of value proposition that you're focused on.
Yeah, I mean, to your point, it's really a delicate balancing act when you're trying to pair revenue and clinical results. And it's almost like we have two programs split in half, depending on who the stakeholders are that we're talking to. Clinicians are, what are we going to do for my patients? How is this better for my patients? And being able to relay that financial story back to the C-suite is another great win. But what we're able to do is we have a tool called PDX, and we have been able to develop this into a really robust tool. Updated it with 72 new rules recently, and this is allowing health systems to really just flip the switch, so to speak, see exactly where their troubles may or may not be, and take immediate action on that based off of the data that they're seeing in front of them. So instead of guessing, well, I think this might be a problem area, which is something that we hear all the time, we actually let the data do that for us, right? There is no more guessing. We know exactly where the problem area is. We're able to target that. We're able to target it at the provider level. I always use the example of CKMB on obsolete testing. Not everyone is running CKMB, right? It's more than likely one or two physicians within the ED that are holding on to it for dear life. So why launch a whole general clinical staff education when it might be just a quick discussion with those one or two physicians, and we can get CKMB to go away. So allowing data, allowing a powerful data engine like PDX to guide the conversation and guide the work is essential, and that's really what we're working on doing right now. It's been fantastic.
So you just added 72 new rules. And how many rules are there total?
There's probably over 100 right now. So we have a lot more in the work queue, right? But we got to do a little bit at a time. So we have 72 new rules within PDX right now. We're developing several new dashboards. We're developing a board called Test Pending at Discharge. And this is huge, right? This is something that is going to get everyone excited at every level in the health system. So much like pharmacy, pharmacy has a drug reconciliation process when a patient is discharged. Laboratory and most hospitals do not. And so when you are discharged from a hospital, you have tests pending. Those results may or may not be crucial. So who's relaying the results to the patient? Who's relaying the results to the primary care physician or the attending that was actually working with that particular patient? Or are they just going off into the void? We know that health systems are penalized for readmissions. And there's a study that 30% of all readmissions are tied back to a test that was pending at discharge. So, what are we doing to work with case management to assign a risk stratification score to that patient once they're discharged, and then actually bring those results into a work queue that case management could then work through? So, that's one of the new dashboards that we're working on developing right now. And the market ramifications for that are just going to be massive, and it's really exciting.
So just to zoom out for a second and just speak in like really plain terms about this issue. You've got all of these people who are dealing with the patients in a clinical setting, and a major indicator that they're looking at to determine what's going on with the patient is a lab result value. And there are rules on which labs are the best possible lab tests to run. And what are those rules based on?
Yeah, so all of our rules are based on it started with choosing wisely. Everyone knows choosing wisely. They had a small list of rules, and that's where everything started. So
And that
that's
was
where
like a group of doctors that were getting together, comparing notes on this and saying, hey,
for the
what tests
yeah,
do
for
you
the most
run?
part, it's
Yeah.
a bunch of professional organizations. Well, we shouldn't be doing this. We should be doing this, and that's where a lot of it started. And then from there, it's really just grown and grown and grown. So, we look at test pending at discharge. We look at Reference lab formulary work, those are two non-choosing wisely events, right? My specialty is molecular testing. Again, most of that is not choosing wisely, but that's founded in sound research that has been reviewed by the medical community and has been accepted. So, we spend a lot of time going back to that revenue conversation about looking at multiplex molecular testing. You know, Speaking frankly, those tests used to be cash cows for the health system. So when I started our laboratory stewardship program, 4.5 years ago, I didn't really touch that in the outpatient setting because there's a massive source of revenue. So why would you cut off a revenue source to a health system? Now in a post-COVID world, those PLA codes have gone away and they're being denied, they're being labeled experimental, and they're being denied close to 72 to 75% across the country. So they're billing those tests out at $2,700 and they're not collecting anything. So we spent a lot of time on multiplex molecular testing, algorithm-driven respiratory testing. What should we be doing based off of your patient population that's appropriate for the patient, that's going to gain the clinical results and information that the clinician needs, but is also going to shore up your revenue on the back end. So there's that balancing act that we're doing, right?
So this is contemplating both what's going to be right by the patient to make sure that we're managing their care, we're identifying if there's anything that they need to be treated for based on the specific lab value, but also the system is saying, well, is this going to basically be is it like a pre-authorization almost where it's making sure that this is going to get paid for, or how should the viewers think about the aspect of the testing where that is that balance of run the appropriate tests and also, by the way, also if it's appropriate it gets paid for, but the tests that aren't getting paid for, they're the ones that shouldn't be run anyway? Is that generally how we think about it, or what do you think?
That's generally how we think about it, but it's hard and it's almost impossible to tell a clinician that they absolutely cannot run something unless you just do a hard stop. But there's always going to be a clinical argument for why that test is actually needed. So it is that balancing act. There are certain DRG codes that, are associated with that test that would allow that, or at least hope that those types of tests would get paid, but that's not always a guarantee. So you can hard code some of that into your system where if you're running that test, you're making sure that you have the appropriate DRGs attached to it in hopes of payment. Um, but it's not necessarily a given, which is why when we tackle a project like this, we look at it based off your patient population. And to break it down high level, it's immunocompromised patients, immunocompetent patients, and pediatrics. And those are your three main buckets. And then from there, you have some decision trees before you would actually run that multiplex molecular test. But we're not saying, let's run a rapid antigen, right? We're not saying let's run an inferior test. We're saying let's run, another molecular test that maybe has four or less targets that will allow the clinician to gain the insight that they need to treat the patient appropriately and get them out the door.
It's interesting. So there it's I think this also gets back to that fundamental reality that a physician doesn't have unlimited time with every single patient,
Right.
and there are loads of patients, and even if that patient is one of your family members, there's just so many different variables in play that you have to decide. So this is one of those cases where technology makes these caregivers bionic in terms of lab testing to make sure that they can always have the best possible diagnostic information. That's the way I think about it. So there's the like immediate tactical aspect of, are you doing the right test right now? Is it going to get paid for? But then if you look out there at a more innovative use case, there are things that you can be predictive about based on risk factors that you're seeing. And this precision diagnostics, or PDX as you referred to it, it's also looking at those kinds of predictive aspects, right? Like, how do I know who the patient is that's going to develop this certain disease in the future so that I can get ahead of the curve?
Mhm. Yeah, we're getting there, right? And I think you really nailed the transition of laboratory stewardship where we're at right now, the influx. That our healthcare continuum at large focuses on sick care. Well, what can we do to actually make that transition from sick care to well care? And to your point, Bradley, it's where are we finding those patient populations? What are those risk factors that we're seeing? What are those mega trends that we're actually seeing within the data set? And that's where we're really going to go to next. It may not be tomorrow, it might be 10 years from now, because the whole healthcare systems need to catch up, mainly the payers. There are HEDIS measures out there right now. There's HEDIS scores and HEDIS stars. 90% of the health systems and payers all pay attention to that. Um, but how do they track it? How do they track the, reward attached to it? When they're using that data, they're using those mega trends to focus on given patient populations and focusing on keeping them healthy instead of treating them when they get into the hospital. So it's that balancing act that we need the payers to catch up with us, where we could really start harnessing that data into well care and start tackling some of those, chronic kidney disease, diabetes, CHF, coag deficiencies. These are all areas that exist within those HEDIS measures that we could assign trends to within the mega data within PDX. Um, but there's no incentive right now for a health system to go out and preemptively try to take care of this patient population. Or more importantly, how do you actually get these folks in to get their screenings done, to get their testing done? So there's still a lot of work that needs to be done there, but that's definitely where laboratory stewardship is going next. And it's really exciting.
Well, and that links to value-based care,
Yep,
which is this whole
100%.
idea that, yeah, paying for or incentivizing transactions in healthcare for healthcare providers really isn't the best model because it has a perverse incentive. If you get paid more for doing more tests, for doing more procedures, for having more visits, you're not going to be as focused on preventing those visits or preventing those tests or keeping the patient out of the hospital, keeping them out of the doctor's office. And what you're referring to is a way to look at these signals that are presenting in this laboratory information, which I say every single day at least 10 times. There is no more comprehensive view into an individual's health journey from birth until death than what can be gleaned from lab information. The second you come into this world, data starts being generated on you from the lab, and it continues to follow you when you're having routine lab tests done for your physical, all the way to where if you are sick and you need something more advanced. So certainly what you're doing seems to be a major lever that can make value-based care a reality, because increasingly it is becoming something that's happening, but it's still not as pervasive as it could be. And I know we talk about patients getting diagnosed optimally, getting treated in the best possible way so they can get better faster. But let's get ahead of that. Let's make it so that people aren't getting sick. People don't need
Right,
the medications. And
right.
then we have this ultimate health situation that can even get into extending longevity. So it's pretty exciting if you really think about it. Like
It's
healthcare is
extremely
really
exciting.
here. Yeah.
Yeah, I mean, it's fascinating what we could do with the data that we already have. Like you said, the laboratory holds all of the data. The disparate systems make it difficult to access, especially across systems. But these are all things that innovators like you could figure out. And how do we bring that together? And what could we do to actually do that transition to well care instead of sick care? It's absolutely amazing. But I go to the example to show why a lot of systems, or not necessarily systems really, Bradley, but payers aren't ready for that. Payers would rather have, I'll use the case of obesity. They would rather have someone come in for a gastric bypass or sleeve rather than treating them up front, with some sort of new drug technology or, different regimen or something like that. So, they don't pay for that, but they'll pay for the sleeve and they'll pay for the surgery. So it's really interesting. It is kind of a perverse relationship. And I think once we do catch up and once we are focused on well care, it's going to be so much better for the country at large.
Yeah, I think technology also and AI, people use the term AI way too much, by the way. I was talking to somebody the other day that was building a system that's basically a form automation system that collects data, has nothing to do with AI. But he said, well, and that's the step where the AI is used to gather the information. I just let him go, but I'm like, yeah, not AI. But in this case, we're talking about actually using AI to identify these signals in the data to surface the best possible testing that not only contemplates, like, hey, this is intuitively what should be tested, but also starts to connect the dots between historical patterns of when these tests are run, these outcomes end up being better. patients end up getting better faster because they get treated better, or the illness is prevented. And then you can start actually underscoring the value of lab, and making it clear that it's not just about the cost of a test, or just the basics of running a lab test to get a result when somebody's sick. It's about how you can actually use this information proactively to prevent disease, and link the dots between this test being run at this point in time preemptively ends up saving you thousands or tens of thousands of dollars in medical expense because you've prevented the CKD crash, for example. So
Hmm.
just like tell it in a storytelling way. How do people usually present with chronic kidney disease? Like what's the story that happens over and over again where it's not ideal?
Well, usually with CKD, it's going to be, once they're stage 3, stage 4.5, they're coming in, they need a transplant, they're on dialysis, right? So instead of taking care of the CKD, oh, I'm sorry, CKD before, stage 1, stage 2, where they could be managed, paying attention to their EGFR levels, again, looking at that and treating appropriately before it's late stage, and now we're in big trouble, right? So paying attention to, little things like your hemoglobin A1C levels, which really plays into part of chronic kidney disease as well. Diabetes and chronic kidney disease go hand in hand in many instances.
And how
So
do you manage it so that you don't end up needing the organ transplant?
proper screening and treatment beforehand. So there's therapies that physicians will prescribe for their patient populations to, help manage that chronic kidney disease, to not allow it or slow down the progression to those late stages to where you're on dialysis and you actually need that transplant one day. So, but it all comes down to proper testing. Looking at your EGFR levels, your creatinine, your BUN, seeing where they're at over time, tracking and trending it, and really staying on top of that particular patient. But it's also the patient needs to stay on top of that too. So it's a two-way street, right? You can't just have, a health system going out there and trying to target a population. You really need the population engaged to come and get tested and pay attention and be educated about, their disease and where they're at and what they need to do to manage it appropriately.
So this is the risk signal that allows you to do care management. So if somebody it can't be prevented, but you can do care management to manage it as more of a chronic disease that doesn't result in the worst possible scenario, which in this case is having to have an organ transplant,
Right.
which now you talk about the cost of that and the impact on the individual's life and their lifestyle. It's so interesting. We had a recent podcast, a really close friend of mine named Chris Liu. And Chris is one of the most inspiring people that I've ever known. I had the pleasure of having him as an intern and then an employee at a company that I had founded back in the 2005 timeframe. And as a 28-year-old young man, able-bodied, actually incredibly athletic, he became paralyzed in a freak accident. And you can listen to the podcast episode to hear about his story, which is worth listening to. But when Chris got through the first, I think it was maybe 60 days of rehab following the spinal cord injury, that's when insurance ends and they transition you to like basically steady state, which there's still a lot. It's a long term project to
Uh-huh.
restore any kind of spinal cord injury. And in his case, he recalled that the hospital, or I'm sorry, the health plan, the insurance company was willing to purchase a $60,000 wheelchair you could drive around with your mouth, but not willing to spend a dollar on continual rehab that could allow you to actually restore the function of your limbs. And in his case, he was fortunate to be educated and have support from others that got him into some programs that ultimately he restored full. I mean, he still limps, he has certain paralysis, but his arms and legs and hands, and he's a miracle. Like he can walk, he can do things. And part of it was the severity of his spinal cord injury. There are certain injuries where you just can't recover like that. But it also another part of it was the rehab he was able to continue. And so the cost now, like for him, he's able bodied, he's working. He actually created a whole organization called NeuroHope that brings this extended care to other people with those kinds of injuries. But I see these examples across all different aspects of healthcare where the thought is if you're acutely ill with something, we'll test you, we'll figure it out at that moment once you're sick, and we'll fix it then. And what we have here with precision diagnostics is this chance to completely transform the way that these signals that are being generated from lab are utilized to drive care management, to drive prevention, to drive identification of those people who ultimately could have a certain disease. Another example that's very out there but real is where we've built a model at HC1 that predicts who's going to develop cognitive decline based on this pattern recognition of historical, just routine lab test values. So imagine that, where you've now got treatments that can dramatically slow down basically the plaque that builds up in your brain that causes this, in many cases, dementia. In those cases, you could actually start managing that proactively so that people never end up in that state where they ultimately lose their mental capacity to live a good life, a happy, healthy life. So anyway, I get enthusiastic about this because it's just so powerful. Like we literally are transforming, you are transforming the way that patients are managed, the way that, and I shouldn't even say patient. To me, it's about an individual's health journey. And ideally, we prevent those individuals from becoming patients, right?
Right.
And this,
That's the idea. That's what we're on the precipice of doing right now. Of, being able to prevent those long-term hospital stays, those invasive procedures, just like Jason and his team are focused on blood management and conserving that. Well, we need to be focused on conserving testing. We need to be focusing on, keeping the patient healthy, not into the health system, and really be forward looking on what we could do. I was at a conference in Chicago a couple of weeks ago, and to your point, Bradley, about, health care and the cost, going back to early stages of chronic kidney disease or whatever it may be, it was a really interesting chart where it really put it out across several different stages. And stage one might have been 1,000 or something like that a year, stage two maybe a little bit more, but by the time you get to the latent stages, now you're up in the tens of thousands, hundreds of thousands, depending on what it was, because you're looking at transplants, you're looking at long-term stay, you're looking at a lot more in terms of overall care. So we really need to work on using those mega trends in data, targeting those patients that are in early stages across several different disease states, and keeping them healthy and getting them on the appropriate course of care sooner rather than later to keep them out of the health system.
So Chris, if folks want to learn more specifically about your work, where should they go?
Give me a call. Go to the HC1 website. You can find all the information that you need there. I'm also on LinkedIn, and I'm always happy to connect and discuss laboratory stewardship. It's my passion. It's what drives me every day. It's really what keeps me going. And being here, it's really interesting because now not only am I working on laboratory stewardship and client facing, with our clients on a day to day. I'm also driving the direction of our project or of our program, which is PDX, where we should be going to next, what we should be looking to, and being able to reach out to a much larger base. So it's great, and I'm really enjoying it.
Well, that's awesome, Chris. So appreciate you being on. The healthcare system is really depending on folks like you who can bring these capabilities to life and ensure that people are being tested in the optimal possible way. In terms of the Boombastic health community, I know that we have a lot of people out there that are extremely interested in ensuring that healthcare shifts to this more well care, as you put it, model from the sick care model, and the progress that you're making to drive that transition. It's commendable. Very few people out there have this kind of capability, and I think taking the knowledge that your team, and all of the clients have benefited from, and infusing that increasingly into technology that then powers up all the caregivers to deliver the best possible outcome for patients it's powerful, and I think it's just going to keep getting better. So thanks so much for being on the podcast. Thank you to everybody out there in the Boombastic Health community for joining. We'll look forward to seeing you next week. And Chris, thanks again for being on the show.
Yeah, thanks for having me, Bradley. I appreciate it.
Awesome. Have a great day. We'll see everybody next week.
Bye-bye.